everybody? Good evening. Not good enough. Hey, everybody. Good evening. Welcome to another MS Views and News program, our second one in Roanoke. And the good news is that we'll be back again, all right? Because next year, many rural areas of the United States are going to get to see us, because that's exactly what we're doing in 2019, is we are providing educational programs, bringing it to the people who can't get to the metropolitan areas of the United States. We're going to bring the programs to them, and it doesn't matter if you're 20 people in the audience or if you're 100 and something people in the audience, but it doesn't matter because we're just going to be bringing the programs to them. So tonight's program, I'm not going to be doing a lot of talking here, right? Tonight's program is called Compass to Care, and what is that? It's a gathering of information about the other aspects about multiple sclerosis. Nobody up here today is going to be speaking about the medications. They're going to be speaking about other aspects, and that being Dr. Landrio, all right? So first, though, I want to let you know that we have three major supporters of tonight's program, and I hope that you all appreciate it. The first is Sanofi Genzyme. Thank you. The second is Genentech. Thank you. And the third is Celgene. And we're going to thank them as well. All right? Plus, I actually have a fourth. I have to thank the MS Alliance of Virginia for allowing us to be here again today. So let's thank them. Very good. Excellent. All right? Okay, so next we have Dr. Landrio. So he graduated Tufts University School of Medicine in Boston in 1993. He completed his neurology residency at Tufts New England Medical Center in 1997. He was neurophysiology fellow at Harvard's Beth Israel Medical Center in Boston in 1998. Dr. Landrio then joined a large neurology neurosurgery group covering the Winchester Medical Center in Virginia for 8 years, founding his own practice, Neurologic Associates PLC, in 2006. He's board certified in neurology and sleep medicine. He's the medical director of the Center for Sleep Disorders in Winchester, Virginia. Dr. Landrio practices general neurology with a focus in multiple sclerosis and sleep medicine. He has over 300 patients with relapsing forms of multiple sclerosis, and he's the medical director of the MS Center of the Shenandoah Valley. So let's welcome Dr. Mark Landrio.
Great, and thank you so much for joining us today, and I appreciate the gracious introduction, Stuart. So I'm going to talk about the importance of early diagnosis and treatment in multiple sclerosis. And as you know, multiple sclerosis is an autoimmune disease in which the immune system is attacking the myelin on the brain and spinal cord. And I like to use the analogy, it's kind of like in high school where your locker key opens your locker, but it also happens to open a locker 2 or 3 doors down. So your immune system fights off some cold or flu or trigger, but then even after that trigger is gone, your immune system mistakenly identifies the myelin in the brain and spinal cord and thinks the battle's still on. So these white blood cells come out, damage the myelin, and then retreat. And that's why we have this relapsing, remitting type of presentation. Many of the other autoimmune diseases, such as rheumatoid arthritis or psoriasis, in those situations, the immune system is just making a different mistake and identifying a different part of the body that it's attacking. And you'll notice that many of the medicines we use in treating MS often work in other autoimmune conditions as well. In terms of the overall scope of the disease, there's approximately 2.3 million folks worldwide that suffer MS, and of those, about 400,000 or so are here in the United States. 2/3 of that group are female, and it is true that women are more prone to autoimmune diseases such as MS or rheumatoid arthritis. Oftentimes patients will ask, well, am I prone to inherit MS because my mother or other family member has it? But it's actually that overactive immune system that makes you prone to it rather than the actual disease itself. There are certain groups that tend to be more prone to have aggressive forms of MS, particularly men or African American community. There's been an association between where you spent your childhood relative to the equator that also plays a role. If you'd spent your childhood closer to the equator and then moved away, your risk is lower, whereas folks who grew up in Canada and moved to the Bahamas unfortunately don't have that advantage. They also have noted an association with low vitamin D levels. During the Gulf War, they had studied recruits and how they measured their vitamin D levels initially, but then over time followed the frequency of developing MS. Folks that had lower vitamin D levels did seem to have a higher incidence of developing MS later, and that may also tie into that equatorial association. In terms of the forms of MS, we often talk about relapsing remitting or primary progressive or secondary progressive. And you have to remember that this nomenclature really came from a time when, as neurologists, we didn't even have CAT scans. So essentially we had folks that would come into the office, they'd have a spell, get better, have another spell and get better. So they call that relapsing remitting. Other patients would have an exacerbation. It then seemed to deteriorate steadily from there and couldn't really pinpoint when their last exacerbation was. And in that setting, they called them primary progressive. And then yet there were other folks who had kind of a relapsing course initially, but then were stable for a time until they hit 65 or older, and then seemed to get weak again and deteriorate. Now that we have MRI and we can actually see the lesions, it's a lot clearer that oftentimes folks that would, in the past might have been called primary progressive actually have a rather aggressive course of MS. And if we put them in an MRI, we'd see they were having very frequent lesions, and being on the higher efficacy medications we have now, that can be curtailed. The secondary progressive group, many neurologists are starting to think of that more akin as a relative of post-polio syndrome. And you may have had relatives that may have suffered polio years ago, and in that setting, they would have issues with getting better from polio at the beginning, and then many years later might have difficulty walking up the stairs. And the reason being is that there's a certain number of nerve fibers that allow you to move your right leg. And if you start off with a certain number, that number deteriorates over time. Now, if you started out with, say, 100 when you were younger, normally losing about 25% of those, imagine if you had an insult to your spinal cord and lost half of them back when you were 30, now you're deteriorating from a lower number. In terms of the diagnosis of MS, MS can present in different ways in different patients. And certainly one of the most common presenting symptoms is with changes in vision, whether that be blurred vision or double vision if there's lesions in the brainstem. Certainly issues with swallowing or chewing can also be an issue, particularly if there's lesions in the brainstem proper. Oftentimes weakness or numbness is a very common presenting symptom in MS, and that even caregivers would notice. In terms of numbness, that also is another very common symptom. The trouble for us as neurologists is that oftentimes patients that have numbness or weakness and present in the office will have it in a strip or swathe down their limb, and that usually comes with a pinched nerve in the neck or low back. Trouble is MS doesn't respect those type of borders. And so with MS, because the lesion's in the central nervous system, we might have numbness or weakness in a whole limb or side or on the trunk. Those are areas that no one pinched nerve in the back could ever present with. So it's really the suspicion is incumbent on us as neurologists to wonder, could this be a central issue, and do we need to look into it further? As you know, these symptoms that I've just described are really kind of the tip of the iceberg that we can see above the water. But the most sinister symptoms that can come along with MS, and why it's really important for us to diagnose it early, is the fact that you can have lesions in more quiet areas of the brain that are responsible for memory or concentration or emotion that I can't test with my reflex hammer or tuning fork. And so this is why it's really important to have MRIs on a regular basis, and not to say, well, I didn't have any symptoms, so I'm going to skip my MRI this year, because you could be having lesions you're not aware of, and those could lead to cognitive disability in the long term. As you know, because MS is an inflammatory process, there's a loss of myelin on the nerves in the brain and spinal cord. If that happens in small areas, then you can end up with trouble with slowness in the conduction through the nerves, but myelin can actually grow back. The axon itself, unfortunately, doesn't, and that's why we can have a loss of brain mass. And that's why when we had lower efficacy agents years ago, we saw a lot of brain atrophy, and that was something that really has become something that people follow. I often use the analogy with a MS attack that it's a lot like a bee sting. The actual insult is small, but the inflammation around it causes a lot of collateral damage. So it's very important to kind of jump on top of that and prevent that collateral damage. The way we look at things now, one new lesion is one lesion too many. And you have to, with any of the medicines that we use in treating MS, we have to weigh the risks, but we also have to remember that the disease itself has risks. And the chance that that next attack could leave you with a loss of vision in one eye, or affect your ability to walk, or your continence, or could change your cognition, that's a real risk too that has to be considered. One of the things that comes up in terms of diagnosing MS early is that the first word in multiple sclerosis is multiple. And so if we only see one lesion on the brain MRI, we've got to find another lesion to make the diagnosis. And so one of the things that certainly we will use the MRI to look at the cervical and thoracic cord. We can do a test called a visual evoked potential test, which will show us if there's ever been optic neuritis behind either eye. When we don't find lesions with those two tests, then we're left to use the spinal tap to look for oligoclonal banding or myelin basic protein, which will cinch the diagnosis for us. We also do tests looking for vasculitis, like Lyme disease or lupus, that could also masquerade and look somewhat like MS on an MRI. The lesions are typically perpendicular to the ventricles or in the corpus callosum, so that sometimes will help the radiologist. A very careful history is also very important. And a patient may give us the answer, and I remember my chairman, Lou Kaplan, telling me as a resident, Mark, if you've heard the story from the patient and the history, and you still don't have a good idea what the diagnosis is, it's unlikely the exam's going to give it to you. And so a patient who reports hand numbness, it's important to ask, well, is it the whole hand, or is it only one finger? Numbness in the thumb could be from carpal tunnel, or it could be from the C6 nerve root in the neck, or if the patient then is questioned and had numbness in the face and trunk and maybe in the foot, perhaps it's in the thalamus inside the brain on the other side. If the numbness is only on the trunk and the leg, it could be in the spinal cord. So a careful history will often steer you in the right place and make sure you get MRIs in the appropriate place so that you don't miss a diagnosis. There are two patients that I'll tell you about briefly. One patient in my practice was a 30-year-old woman who had a very spastic gait, and she'd had an MRI of her head, which showed one small lesion, and they had MRI'd her thoracic spine and didn't find anything. So they were going to have her come back in a year or two and do a follow-up MRI. The trouble was, she still had a very spastic gait, and when we did her MRI, when she came to see us, we did the MRI of the cervical region, which they had omitted, and that was where the lesion was. So you have to look under all three of the walnuts and not miss a lesion that would have delayed this woman from being treated appropriately for a year and a half. Studies have shown that because MS is an inflammatory disease and so very early, you want to jump on that and early in the course, because if you don't treat that inflammatory disease early, you'll never be able to reach as low a level of disability at the end. If you wait, those patients will never catch up with the ones that were treated more promptly. In terms of a second patient, was a teacher who was sent to my practice, and she'd had a foot she couldn't move on her right side. It was there for about 4 weeks, and a spinal surgeon had sent her to me, and I was there to do a nerve test, which I did, and it was entirely normal. And it would have been very easy to say, well, okay, your leg is fine. The issue was, so then I went to and queried her and said, well, have you ever had any incoordination or stumbling or trouble with your vision? She said, well, you know, I did have trouble with my left eye 3 years ago. It got blurry, and I saw an ophthalmologist, and they ordered an MRI, and my insurance company declined it. And then it got better over a few weeks, but then a year later, I had it again in my left eye, and I saw a different eye doctor, and they tried to get an MRI, and it was refused again. And this woman, when I examined her, was unable to be coordinated with her left arm. She walked very stiffly. She had upgoing toes, which suggested a central nervous system insult. I ordered an MRI, and they declined it. So I ordered visual evoked potentials, which proved that there was slowing behind the eye, and I was able to prove that she had MS and get all of her scans, and this woman was put on a high-efficacy intravenous medicine, and actually her deficits have largely resolved. So sometimes the insurance company can be an obstacle to patients being diagnosed and treated appropriately as well. In terms of early evaluation, all patients that come to our practice, we get a JC index. Biogen does help to offset the cost of that, but it does give us a sense where patients have ever been exposed to the JC virus. That virus is present in about 54% of the population, and it can increase the risk of PML in folks that are on certain immunosuppressive medicines in the long term. In my practice, we had worked with the studies, the Stratify studies, to establish the utility of that. Now, in terms of I talked about the window of opportunity early in the course of the disease. Years ago, we would typically proceed through different injectable therapies, and now induction or treating aggressively at the beginning has really become the mainstay of treatment. One other thing that's important in terms of the early diagnosis and treatment of MS is also identifying folks that have neuromyelitis optica, which is a aquaporin 4 antibody. These antibodies will cause lesions in the brain around the ventricle and can cause symptoms that are including recurrent optic neuritis. I had one patient who had quite a number of bouts of that, but also can cause lesions in the spinal cord and some atypical lesions in the brain. One young woman who was 28 in my practice had 5 bouts of optic neuritis, some in either eye, and had been on a high-efficacy infused medicine and had 7 new lesions in 3 months on it. And so these folks don't respond to typical MS therapy and actually have to be treated with conventional immunosuppressants. So identifying those folks is really important. Now I'm going to shift gears and look at relapse management and recovery once we've had one. And hearkening back to that bee sting analogy I mentioned before, you have a small lesion and inflammation around it. Well, the best thing to do at that point is to jump on it with IV steroids, prevent that collateral damage, and then we have to look at, well, where do we go from there? Now, one of the things that's important to mention with a relapse is there are true relapses, as I like to call them, and then there's what we call pseudo relapses. If you've had an old lesion that caused weakness on your right side and numbness, and it went away, but every time you get really, really hot or have a fever or a bladder infection, you feel some of that numbness again, that's not really a new relapse. It's really a re-expression of previous symptoms. Essentially, those neurons that are compensating for that old injury, kind of the side routes around the highway, are blocked off, so you start to re-express the symptoms. But if we were to do an MRI at that point, we wouldn't see any new lesions. In contrast, if your weakness and symptoms were always on the right side, and all of a sudden you develop left-sided symptoms, we can't explain that on the base of that old lesion. And there, our suspicion for a new lesion should be really high. Typically, in our practice, if a patient is calling in and has a new symptom of that sort, we bring them in right away, examine them. If it looks that way, they're getting an MRI by midday, and if there is a new lesion, they're getting IV steroids in the afternoon. In the past, we used to talk about having only 1 or 2 lesions a year was actually considered pretty good. And with the agents back when I was in training in the 90s, that was pretty good. But nowadays, this concept of NEDA, no evident disease activity, is really our goal. It's to score a touchdown, not just to get first downs. I like to use the analogy that if I was in a room of stroke patients and I said, well, if you have 1 or 2 strokes this year, we're going to leave your blood thinner alone. But if you have a third one, then we're definitely going to change your blood thinner. No one would see that as acceptable. So why in MS would we settle for that either? We really want to be proactive and use our most effective agents early. It's also important that as a patient that we're very proactive in not minimizing symptoms. It's easy to say, well, geez, my arm feels numb, but maybe I slept on it wrong, or it's probably not important. I always encourage my patients to take the impetus and call and let us decide whether it's important or not, rather than dismiss it, because we hate to miss a new lesion. Certainly engaging the rehab team early is also very important. That helps to expedite recovery, improve mobility. And as we know, when the body doesn't move, we're more prone to gain weight, get bed sores, and the like. Depending on the nature of the deficit that the relapse causes, physical or occupational therapy is in order. If there's issues with swallowing or chewing or speaking, speech therapy is also of great help. Now switching to what is a comprehensive healthcare team in relation to MS. And this has really evolved over time. In addition to your neurologist who's who's treating relapsing MS, your primary care provider also has a role here because they have to keep the rest of you healthy, follow your blood pressure, your cholesterol, your general health. Certainly any disease that causes you to have disability and immobility is going to put you at increased risk for gaining weight, getting diabetes, and other conditions of that sort. So certainly the primary care provider is very helpful in that regard, and also in monitoring for renal and liver function issues. Having a personal trainer and exercising regularly, I think was very clearly mentioned in the previous talk, and it's really important. Anything that would cause someone who doesn't have MS to get weaker and lose ability is certainly going to be amplified in the MS community. Certainly, I like to use the analogy, and I tell my patients, moss doesn't grow on a rolling stone. So if you keep active and keep using your muscles, you're not going to lose the capacity to do that. And even in the folks that can't walk very far, I say, well, set a distance that you can walk and do it repeatedly so you stay acclimated to it. Occupational therapy can be helpful in terms of improving hand function, utensils, eating, braces as well. We tend to involve ophthalmologists because they can do what's called optical coherence tomography, which looks at the thickness of the retina behind the eye and can be a very good monitoring tool to see if you're accumulating optical fiber loss. They also can make sure that you're not losing visual acuity or losing visual fields that might impair your ability to drive and also might adversely affect your quality of life. Caregivers also play a role here, assisting in transfers, being vigilant for new symptoms that we might either not notice or ignore. They also are very helpful in ensuring medicine compliance and helping to relay concerns to the healthcare providers. Speech therapy this also can be helpful in terms of patients that have difficulty swallowing. They can add thicket to their beverages or suggest a pureed or soft diet. Also, they can instruct regarding the chin tuck maneuver to improve dysphagia issues and minimize the chance for aspiration pneumonia. When we talk about how and when to extend your healthcare team, this is a situation where if you're accumulating physical disability in that situation, then certainly that's a place where physical and occupational therapists, we want to get them involved. And if you're having vision changes, that would be a time we would get ophthalmologists to come and help us to assess it and get baseline visual fields so that we can see where the deficits in vision are and so that we can monitor that as well as the OCT, as I mentioned previously. One of the things that people often might not think of first off is employing someone who is facile in applying Botox in the treatment of spasticity. And certainly folks that have had MS lesions in the brain or spinal cord can have spasticity and trouble ambulating. And oftentimes this can really affect quality of life or even the ability to ambulate at all. In my practice, I have one patient who's in her mid to late 60s, and she'd had an MS lesion that left her very weak on her left side. Her right side's quite strong. The trouble is her balance is rather suspect when she's up and about, and she has a touch of diabetes as well. Well, when this insult had happened to her, she found herself over time with a very contracted right hand, and although the physical therapist tried to get her up on a walker, she couldn't use it because she had one hand she could hold it with, but she could only palm it with the other hand. And so using Botox, I was able to loosen the grip of her hand so that she could open it far enough that now she could actually grab the walker and use it effectively to get about. So there, a small amount of Botox really made a huge difference in her quality of life and also helped with her ability to keep the hand clean and prevent infection there. In terms of patients that have bladder spasticity or urine retention, bringing in a urologist is also very helpful. They can do procedures to help to make sure that there's no structural impediments. Also, in terms of using, sometimes they'll use antibiotics in a chronic fashion to prevent infection, as well as use agents like that can help to antagonize bladder spasm that can also cause urinary issues in terms of continence. In terms of medicine side effects, this can also bring in other specialists depending on the agents that we use to treat a patient with MS. Certain immune modulatory medicines can affect thyroid function. In that setting, whether it be high or low, bringing an endocrinologist in is really a great help. In other situations, there can be issues with immune attack in certain areas in the kidney, in which case a nephrologist would be someone who would be brought into the healthcare team. Other medications can cause issues with the GI tract and irritable bowel type symptoms, in which case a gastroenterologist may also get brought into the mix. Now, in terms of one other feature that's often forgotten in the case of dealing with the healthcare team, and I think one of the earlier questions that talked about weight management in terms of MS, is daytime fatigue. And many MS patients, when queried, will say the fatigue that goes along with MS may be one of the worst symptoms they experience. And often patients will ask me, well, why is it that I'm so tired? And my response is often, well, before you knew you had MS and you had the flu, how did you feel? You felt tired. And the reason was because your body is making white blood cells, T and B cells, to fight off this cold or infection, whatever it is. Patients with MS, their immune system is making these T and B cells mistakenly because they think there's an infection or something to fight off, but it's still the same drain on your overall energy level and level of function. So that can cause fatigue in its own right. But that's amplified by the fact that anything that makes patients that don't have MS tired in the MS setting may make you feel even more tired. And so trying to minimize those in terms of having a healthy eating lifestyle, as was mentioned, minimizing alcohol intake plays a role, but also many patients with disability will not be as active as they were. Their diet doesn't change, but their activity level does. And that can cause them to gain weight and then be less mobile or have orthopedic problems such as hip or knee problems. And so in that situation of the weight gain, they can tend to have issues with snoring and hypertension. And we also look for many of the medicines that we use to treat MS can also make people feel more fatigued and tired. Medicines like amitriptyline and nortriptyline that are used for headaches, medicines like baclofen and Xanaflex can make for muscle spasticity, can be very sedating. So oftentimes we're trying to, of the medicines we're using, minimize the ones that might amplify that fatigue type side effect. Other medicines that are often used, especially in our folks in their 50s and 60s, are medicines like beta blockers and calcium channel blockers, which can sometimes cause fatigue, but also can slow heart conduction, which can be a side effect that can be amplified depending on what disease-modifying therapy they currently take. One of the things that's sinister about sleep apnea and poor sleep hygiene is that one of the things that's important for you to feel refreshed during the day is that you've gotten through the normal cycles of sleep during the course of the night. And that means that you have to go through slow wave, deep sleep, and REM sleep, and go through several REM cycles. The thing is, when we're asleep, and when we get into REM sleep, our muscles are most relaxed. And that's true of the muscles around the throat as well. Mild pressure there can cause the snoring noise, but if it actually blocks the airway off, your oxygen level drops. So your brain thinks you're being choked. So what does it do? It wakes you from deep sleep to light sleep over and over and over through the course of the night. And oftentimes patients will come in and say, "Doc, I sleep great. I sleep 8 or 9 hours. But when I get up, I'm exhausted." And the reason is that they're not getting REM sleep, so they don't feel refreshed. But the other thing that happens in not getting REM sleep is that REM happens to be the area where short-term memory is moved into the long-term storage in the hippocampus. So if every time you're putting that book back up on the shelf, you keep dropping it, by the end of the night it never gets stored properly. So then the next day patients will say, "You know, my short-term memory is not very good. I remember the chronic things, really old things well, but I can't remember where I left my keys. I can't remember that I was supposed to have this appointment." And so oftentimes sleep can adversely affect memory that way, or concentration at work during the next day. The other thing that sleep apnea can also disturb is when those oxygen levels get low, your adrenal glands see it as an emergency, a fight or flight response, and they dump adrenaline in the bloodstream to get you to breathe more. Well, that adrenaline is a very potent stimulant for blood pressure. So it increases blood pressure during the night when it's normally very low, but then that effect persists through the next day. So oftentimes we'll have folks that come in on 3 or 4 blood pressure medicines. Again, some of those, like the beta blockers, can make people feel logy and gain weight as well. One of the last of the sinister effects with apnea is how it affects this ratio between 2 hormones called leptin and ghrelin. And leptin is a hormone that tends to suppress appetite, and it increases metabolism. So when leptin, like a seesaw, is up high, your appetite is low and your metabolism is high. When apnea is untreated, that seesaw goes the other way with ghrelin higher. And when ghrelin is a hormone that's made in the stomach, and it's a potent stimulant of appetite, but it also slows metabolism. So when it's high, it tends to make folks gain weight. So treating the apnea returns that seesaw back to the homeostatic situation, in which case folks are able to maintain a more normal body weight. So we encourage our patients to, if they have a habitus or symptoms of fatigue, oftentimes to get screened for that. It also helps us in facilitating their eligibility for certain medicines and stimulants that can help them with energy during the day in that setting. Lastly, I'm going to shift to understanding shared decision-making in your healthcare team. And in this, it's really important, as I kind of alluded before with the numbness in the hand, that you describe your symptoms really precisely. And certainly dismissing the symptom and not describing it completely, sometimes the neurologist will miss out on making the diagnosis. Now, that doesn't excuse us from asking the next question about, does it involve the trunk or does it involve some other bodily function? Certainly speaking up about side effects on medicines is also very important in being a participating part in your healthcare team. It's very easy for me to write a prescription for an injectable medicine and assume my patient took every one of those syringes. And when I first went in practice, I thought that was the case. And then as I got a few gray hairs over years, I realized there were often syringes left in the fridge at the end of the month. So if you're not taking the medicine as it was approved, you're not even getting the benefit that it was originally supposed to give you. Some medications that are twice a day, if you only take them once a day, you may not even get a benefit over sugar pills. So it's really important that you're able to tolerate the medicine as it's prescribed, or bring it up with your neurologist and say, you know, the medicine may work really well, but I'm not tolerating it well. Many of my patients in the past who were on different types of interferons might have flu-like symptoms for a day or two after their injections. In that setting, it's easy for me to tell them to take Tylenol or Motrin and tough it out. But if you multiply that out over the course of the year, that's 104 days a year that they feel exhausted or tired or don't want to go to their children's games. So that really affects quality of life. And so and it may be that they don't take the medicine because of that reason. So important that you speak up in that regard, or whether you're having injection site reactions or other symptoms. Some of the newer agents do require us to do a fair amount of blood monitoring as well to look for side effects. Even the best MS medicine in the world, if you're not able to tolerate it, isn't the best medicine for you. Now, it's certainly important for your treating neurologist or nurse practitioner or PA to listen and be engaged in conversation, and also they should have comfort with all of the medicines that are currently available to treat MS. Certainly, as the medicines become more complicated, it's important that we know how to deal with the side effects and also be able to explain that balance between risk of the medicine and risk of the disease to make sure that that's an appropriate balance and that we're using the appropriate agent in a certain person. It's also very important that they're willing to let you, the patient, be engaged in that conversation. And lastly, it's important to include assessments from caregivers as well as therapists to avoid the symptoms being minimized that might allow us not to have really caught a symptom that a patient presented with. And at this point, I will thank you for your attention and turn it over to questions.
Hi. When you were speaking about the Tysabri, you said that you look at the data as far as the JC virus, and I know that the patients need to be tested periodically to see if it's elevated. The normal time span to be on Tysabri is usually 2 years, I believe. If you have any of your patients where it's elevated one time, and it's past the 2-year mark or coming up on it, do you recommend that they come off of that, or do you say, well, let's try a little bit longer, or how would you do that as a doctor?
Okay. In managing patients on that agent Tysabri, typically there's no hard and fast rule that they have to come off the medicine in 2 years. It is true that no patient who's, regardless of their JC index, whether it was high, low, or indifferent, in the first 2 years contracted PML. So essentially, you have kind of a honeymoon period of those 2 years that you could use it regardless of the index. After that, folks that have a higher index have been on previous immunosuppressants such as methotrexate or Nivantrone, or have been on Tysabri more than 2 years. Those are folks that go into that triple risk factor group, and then they're a little more prone to PML in that, or moderately more prone to PML in that setting. The threshold with positivity has been at 0.4. No patients have contracted PML below 0.6, and a few at 0.9, the vast majority over 1. So certainly if it was 0.41, I wouldn't take a patient off a medicine that's working really well for them. But if they're steadily going up and get over 1.0, and I think if you had 10 neurologists here, you'd probably get 10 different answers. But in my practice, typically if folks are going up and getting over 1 to 1.5, after that 2-year mark, that's a patient that I would be looking at migrating them to something else. Certainly several years ago, there wasn't that something else, because that was essentially the only infused agent that we had. Now we do have some options in that setting, but we monitor typically a patient that's JC negative. We check them once a year because, again, even if they become positive, no one's contracted PML in that 2-year period. Once they become positive, if we're leaving in that 0.4 to 1 range, we may check them every 6 months to see if it's, or every 3 months, depending. And fortunately, it's not at cost to the patients because Biogen covers that. But we will check it to see if the trend is that it's going up. Sometimes it drops some. But folks that do get high, it never goes down. So because it's just like if you had gotten a vaccine for chicken pox, that your titer stays high for years. So it's not like you can wait a few months and it'll trickle back down. Also, the thing that I like to use the analogy of chicken pox and shingles. If you never had chicken pox, you can't get shingles later. So if you're among that group that have never had the JC virus exposure, then theoretically you shouldn't be able to get PML. And it is true that the test has a 1 in 10,000 false negative rate. But if you do the test twice and it's negative both times, the chance that it was falsely negative is vanishingly small.
Next question here. Thank you.
I seem to deal with optic neuritis almost constantly.
We're going to ask again that nobody asks questions about yourselves, but make it all general.
Okay, sorry. If you had a patient that would have...
That's exactly what I've done too. Great going.
Maybe say every other week would be having all this pain with the optic neuritis, and you end up taking Tylenol or whatever. What can you really do for it to ease it up? I'm with an eye doctor that's been X-raying it, like you said. Yeah. Huh?
Well,
I'm sorry.
With optic neuritis, certainly the inflammation is something that happens and then it stops, and certainly it's usually treated with intravenous steroids right away. The sooner the better, to try to minimize vision loss. We do VEPs to get the extent for how much of the injury is there. We often will do visual fields as well to see if there's any residual deficit there. It doesn't usually tend to keep occurring every week or two. Certainly it can cause pain initially, but it doesn't usually cause chronic pain in that situation. It's usually the inflammation in the optic nerve that causes the pain. So we would certainly look for other causes of pain about the orbit. And in terms of the vision symptoms, make sure that there aren't other confounding conditions such as glaucoma or thyroid hypertrophy of the muscles about the eye that could also be of issue. Unfortunately, once there is damage to the optic nerve, we can't undo that. But in folks that are having multiple bouts of optic neuritis, that's the time, especially if it's early in the course, would be someone we would consider ruling out neuromyelitis optica in that setting because they wouldn't respond to conventional MS therapies.
In a patient who has stable MRIs, no new lesions and things like that, but symptoms such as fatigue, pain, and things like that are continuing to get worse, at what point should other causes for those symptoms be considered?
Well, I think that's a very good question. The fact that there's pain, or, in particular, in a situation where you're not having any new discrete spell, just because a patient has MS doesn't make them immune from all the other things that could cause pain in a limb or pain in the back or elsewhere. Certainly, issues like trigeminal neuralgia aside, oftentimes I'll be called to do a nerve conduction study on a patient who has arm or leg pain, and it turns out they have an L5 nerve pinched in their back too. So, that was one of the reasons that one MS patient I alluded to earlier came in. She couldn't move her foot at all, and they thought, well, maybe she has a pinched nerve in her back. It turned out she didn't. But oftentimes, patients may have carpal tunnel or a pinched nerve in their neck that gives them arm numbness. So we try to look to make sure that we're not missing any other remediable cause of pain before we just blame it on MS. Certainly, in the brain, there's an area called the thalamus, which is essentially kind of the wire harness for and main center for relaying sensory information. Lesions there can give you burning pain on one side. I have one patient in my practice that we use neuropathic pain medicines for, and those worked far better than the Percocets and Darvocets that he was given before, because it's nerve endings that are reporting misinformation rather than a particularly pinched nerve.
Next question.
Can you explain the phenomena of oscillating fatigue and then crushing insomnia in MS patients?
Fatigue and insomnia. Well, the insomnia is a very complicated topic because certain medications we use can cause that as a side effect. The fatigue part, I think I touched on earlier, where your body is making T and B cells continually to fight off essentially the immune system thinking it's fighting something off, but really just to promote this autoimmune attack. And so that can cause a baseline of fatigue. And certainly things like sedating medications, medicines for spasticity, untreated apnea are all things that can amplify that in an MS patient beyond what someone who doesn't have MS have. In terms of the insomnia, if a patient's on medicines like Provigil and Nuvigil for fatigue during the day, if they're taking it twice a day, sometimes we'll discontinue the evening dose and see whether they can get away with just the morning dose to avoid the insomnia at nighttime. Oftentimes it takes a thorough review of their medicine list, and then also looking at their sleep hygiene to make sure that they're not essentially in a situation where they're sleeping too much during a different part of the day and then don't have enough sleep inertia to get to sleep later in the day. So those would be all things that would figure into an assessment of those complaints.
I have a question. If you have a patient who has never had any major health problems, and this is indirectly related to multiple sclerosis, what is your recommendation for a patient who has not had any major health problems, and when it comes to taking the flu vaccine and they've never taken it, what is your recommendation about them taking the flu vaccine?
So you're asking regarding a patient who does not have MS, who just wants to take the flu vaccine?
They have MS.
Oh, they have MS and they're taking the flu vaccine.
And have never taken the flu vaccine before.
Generally, with vaccines, the recommendation is if it's an unattenuated live virus or an attenuated weakened virus, those are generally discouraged in the setting of being on immunosuppressant medicines. I think it depends on the agent that the patient is taking. The one that it comes up most commonly is with the shingles vaccine. And in the past, the vaccine was weakened but not actually inert. The new vaccine that's out is actually completely inert, so it's safe to use. I have patients in my practice that get the flu shot regularly and have done well. I think that if we had a few neurologists here, I think you'd find differing opinions on that. I have not discouraged my patients from getting the flu shot because of the risks of them getting flu and having other complications, particularly if they're older or debilitated to start with, if that answers your question.
If someone would often sleep like 12 hours a night and was taking Provigil, and would you, like once a day, would you maybe add another Provigil or either tell them to take the leptin, like you mentioned earlier, a vitamin every day?
Well, leptin isn't typically given as a supplement. The 12 hours of sleepiness, that's a long time to sleep. Most adults usually sleep only between 6 and 7 hours. So to sleep more than 10, 12 hours not being on some other type of sedative might make me start to ask some other questions about snoring, whether that person has some susceptibility to sleep apnea. Even in folks, there's often a misnomer that you have to be kind of heavy to have sleep apnea. It really matters more about how big the aperture in the back of the throat is. Some folks, you can get apnea from a blockage behind the uvula and soft palate, or also behind the tongue. So they call it retropharyngeal or retroglossal obstruction. And so in that setting, some folks have a rather larger tongue and it makes them prone to it. Or just the back of their throat is rather narrow. And so oftentimes body habitus isn't a total giveaway for apnea. Also, if you've had previous stroke or central nervous system insult, as we'll see with MS, then that side of the pharynx isn't as strong. And studies have shown that even in the stroke community, 60% of folks that have had a stroke will have some degree of sleep apnea due to pharyngeal weakness on that side. So oftentimes we would do a study to rule that out and make sure that that's not a confounding factor in the fatigue, and then reassess the provisional after that, or the timing of it, perhaps not taking taking the first dose early in the day and then the second dose midday rather than in the later afternoon where it might still have effects into the evening.
Do you have an opinion on the clemestine?
Say again, please.
Do you have an opinion about clemestine? So,
Not in terms of my clinical practice. I don't have any patients on that agent.
Okay, next question then here. Did he finish your answer? He said he doesn't know, basically.
but you're familiar with it.
I don't do primary research, and I don't use that agent in my practice, so I can't really comment on using it in my patients in terms of managing their MS.
Great, thank you. Next one here.
Yesterday, I think there were some comments with regard to the effects of symptoms of the MS declining as a person ages. Could you elaborate a little bit on that? I'm not sure I understood that.
Not that their symptoms would decline, but the activity of the immune system in terms of the autoimmune attack loses its vigor. So the immune system can't mount as vigorous a response when you're 75 as it could when you're 30. And so oftentimes we find that and that's one of the reasons why we want to use our most effective anti-inflammatory agents early in the course of the disease rather than save them for a point when the patient's 75 and has a significant disability and then bring them out, at which point most of the damage has been done and we're more into that. We could be into more of that secondary progressive phase. Now, certainly we've heard from patients at this conference that were in their 60s and had new lesions. So it's not that the immune system can't still mount attack on the brain or spinal cord, but just that its vigor is less. So oftentimes we may be able to gradually retreat in terms of the agents that we're using to an oral agent or something that doesn't require as much serologic monitoring, and the patient doesn't have any further breakthroughs. But certainly the symptoms of the patient I wouldn't expect to necessarily decline over time.
Down there? Any on the other side? Okay, I'll be back to the people around here in a minute, but I've got one going right here.
I just wanted to follow up on something you had said earlier regarding basically viruses in terms of flu virus and whatnot, though. Again, would you recommend basically not doing things like flu mist, where it's actually a live virus comparatively to dead viruses, i.e. the injection?
Yeah, certainly a completely live virus those type of administrations are generally discouraged. It would depend on the immunosuppressant agent that the patient was on. Certainly they can vary substantially in terms of the degree that they suppress the immune system, how low the absolute lymphocyte count is reduced. So that would also play a role.
All right, got two questions. You mentioned a clinic where they check the optic nerve damage. Where is this clinic?
A clinic in particular,
Well, you said a particular doctor, I think, when you mentioned it yesterday.
The OCT looks at the retina, and so a retinal specialist would use that. I don't know that I mentioned a ophthalmologist in particular, but many ophthalmologists will have that apparatus, not just generally, and in particular, retina specialists will definitely have that, and so that they can monitor the thickness of that neural fiber layer. But that it's a pretty ubiquitously available test.
I said two questions. The second question, Ampria, the walking drug. What is your opinion on a half a dose once daily as opposed to the twice daily dosage if you're prone to seizures?
Well, alluding to the fact that its major contraindication is epilepsy and patients that have seizures, it is effective in only about 50% of the population in terms of improving their ambulatory status in that study that had shown this 25-foot walk. One of the things that I wish they had done when they studied that drug was to look at what it does for hand dexterity or upper limb dexterity, because that's a place where maybe it might also have improvement, but they didn't really look at that. And it might improve somebody's ability to, say, keep their job if they do a lot of data entry. In my practice, patients that have epilepsy, I don't tend to put them on it at all. Certainly, it would seem reasonable that a half a dose might have less effect, but it would largely depend on what type of seizures the patient has, how much in the way of interictal discharges are present on their EEG test, how long their last seizure was. If they'd had one when they were 20, but never had one since and haven't been on medicine, I might feel much more comfortable using it in that setting than in somebody that had a car wreck 2 weeks ago and it might have been a seizure. So those would all be factors that would affect my decision.
Next question here.
Obviously, MS involves the optic nerve, or the optic nerve gets involved in MS, whichever way you want to say it. But I never hear anybody talking about hearing problems associated with MS. Is there a reason for that?
Certainly with MS, it can affect the brain stem, and brain stem lesions are, just by volume, are smaller in terms of likelihood compared to the whole cerebrum and corpus callosum. It is true that the inferior in the base of the brain in the fourth ventricle, there's a structure called the quadrigeminal plate. And there's the superior colliculi that essentially allow, when you shine light in one eye, the other eye to constrict, that consensual reflex. Those inferior colliculi are responsible for relaying the hearing information into the trapezoid body and into the Heschel's gyrus in the brain, which allows you to interpret that hearing information. So certainly lesions in the brainstem could cause an acute disturbance in hearing. As we get older, that certainly there's other factors that could also affect hearing too. But if I had a 20-year-old who came in and said, gee, I had this sudden change in my hearing in the left ear, just lost it suddenly, and had a lesion in that vicinity, it certainly could do that, but would be a rather unusual presentation.
We only have time for like 3 more questions. One of them's here, one's here, and then I'll get another one out there somewhere. And before I let you ask that question, is there anybody in the room that did not yet get a seminar evaluation form? Just show me your hand. All right? And I don't want to know that everybody filled them all out already, because we still have one more speaker. All right? All right, so I got the 2 of you. I'll be to you afterwards. Thank you.
I'm just wondering what your opinion is on non-THC CBD.
In terms of the CBD oil type agents that are used, I think that in my practice, I don't tend to utilize them. I think they can relieve pain in certain situations, and I've talked to a number of patients that have said that it does so. I don't believe it has an effect in reducing MS attacks per se. So I've largely left it in our community. We have a number of pain management physicians that deal with a lot of the pain management. And as you know, the environment in medicine has really changed such that I really focus in my practice to neuropathic pain agents. And we have a number of alternative type docs that will prescribe it. I think to the extent that it's used topically, I don't have any objection to doing that, and it seems like it helps some folks that have come to me. I had one gentleman who we actually see on a regular basis, who I mentioned earlier, had kind of a burning stinging on his entire side. and face, arm, leg, whole side. And it was a lesion in his thalamus that caused that. And they described it as a thalamic pain syndrome. It can be described, and certain nerve pain medicines like trileptal will help it, but sometimes it's really refractory. And I know we have him on a combination of 2 medicines now that are helping, but he's thinking about maybe exploring that to see if it helps in his feet in particular. So it'll be interesting to see what his response is.
Okay, if a patient has a sleep study and the results show that they have severe limb movements during the night, what would you be able to do for that patient?
That's a very good question. Sleep apnea gets the lion's share of the press, but anything that disturbs your sleep architecture, interrupts REM sleep, is going to cause the effect of memory impairment and fatigue during the next day, though it won't cause the high blood pressure type side effects that come from the renal discharge of adrenaline. So if you have 120 leg movements during the night, one of the things we look at is not just how many leg movements there were, but we look at what's called the PLMA index, the periodic limb movement associated with arousal index. So you had a leg movement, but did you have it and it interrupted your sleep too? If we see that, oftentimes I'll have patients that'll come to our sleep clinic and they'll have their sleep apnea treated, and they come in and they're like, "Doc, I'm wearing a CPAP and I'm still exhausted." And the reason is 40 times an hour their leg movements are interrupting their sleep, and the doc didn't treat that. So we often will check a ferritin because their ferritin level's low. It can cause that. Or we'll use certain dopaminergic agonist type agents like pramiprazole is very effective in reducing those leg movements. And oftentimes people feel like their energy level's much better the next day when it's treated. So that's a good question.
Last question.
You were talking about the hearing and lesions in the base of the spine. Would that include like the cerebellum and the spinal where the curve of your neck is?
The cerebellum doesn't affect hearing. It's largely the center of the cerebellum is the vermis, is responsible for your balance and maintaining upright posture or sitting straight. The hemispheres are responsible for your limb movements. So typically it's more in the brainstem proper that we would have, you'd have to have a lesion. Cervical cord would be too low. It has to be higher up at the level of the cerebellopontine angle, essentially below the ear. Up at that level, you'd have to have a lesion in order to interfere with auditory processing.
Okay.
Thank you. And Dr. Landrio, thank you for coming here today.
Thank you, Stuart. I
Quite
appreciate
welcome. I want to thank our speakers, Jeff Siegel, Dr. Mark Landrio, and Paul Pelland. I want to thank you all for being here tonight. Okay? I want to thank our video crew. We got Bill and we got Kevin back there who travel around the country with me all the time. And again, we have to thank those that supported this program. We have Sanofi Genzyme, Celgene, and Genentech. Okay? So thank you all for being here tonight.